Hello to anybody who's on. We're going to start in just a minute or so. Hello, everyone, and welcome to today's webinar, The Latest Treatments for Uterine Cancer and What's in the Pipeline. I'm Kitty Silverman, the Uterine Cancer Program Director at SHARE.
And I'm Corby Arthur, Uterine Cancer Patient Support Coordinator at SHARE.
Before the presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancer, and provides outreach to the general public about signs and symptoms. For more information about upcoming webinars, support groups, podcasts, and our helplines, please visit our website at sharecancersupport.org. Now, I just want to give you a few housekeeping reminders. All participants will be muted during the presentation. Once the speaker finishes presenting, we'll begin the Q&A discussion. Please submit any questions through the Q&A section at the bottom of your screen. Remember that our speaker cannot give specific medical advice, so please keep your questions general in nature.
We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. This webinar is being recorded. We'll share the recording with all registrants in a few weeks, and it will also be added to our website. I'd like to hand it over to our speaker to introduce himself. Dr. Konecny, the floor is yours.
Welcome and thank you very much for giving me the opportunity to share some of the clinical experience that I have and also some research experience that I have, particularly pertaining to endometrial cancer. I'm a professor of OBGYN and medical oncology at UCLA in Southern California. I've been involved in clinical research, but also clinical care of patients diagnosed with uterine cancer for about 25 to 30 years. And I've had the privilege to be involved in one of the panel members' care, and this has led to the invitation to share some of the things that we're working on. I believe I have to share my screen now and get our slides up. I hope you can see this overview slide now with the title, The Latest Treatments for Uterine Cancer and What's in the Pipeline. I would like to make the next 30-40 minutes as educational as possible to really show you what's new in the treatment of uterine cancer, but in an understandable way that equips you also to interact with your physicians and nurses to ask questions on some of the treatments that are evolving. And the more you know, the more you can steer your treatments and the better patients do, in my opinion. So this is very dear and near to my heart that I can share some of the newer findings, how we treat uterine cancer. Now, one of the problems is that uterine cancer is not a disease where we've made a lot of success. It's quite the opposite. The incidences of the disease are rising, and this is summarized in this slide. We have about 66,000 cases in the US per year, and this is projected to rise to nearly double getting to the year 2030. There's a 1.8% annual increase in cancer mortality for uterine cancer, and this is a global problem with about 417,000 new cases globally. One of the problems is that we've been treating this disease in the wrong way as a one-size-fits-all, and we've been behind in progress, which you see across other diseases such as breast cancer or lung cancer or colorectal cancer, because we've still treated the disease uniformly with radiation, chemotherapy, and surgery, but nothing else. And I think this has dramatically changed over the last 3, 4, 5 years based on a novel understanding that although the disease arises in the uterus, they're actually very distinct diseases. They have very different molecular profiles. They have very different signaling pathways that need to be treated differently. And this is a national effort conducted by the TCGA over the last 10 years, which analyzed with great depth specimens from patients diagnosed with endometrial cancer. And they have generated a multi-omics, genomics, proteomics-based classification into 4 molecular subtypes, which are very, very different. And they're summarized here. One is the POLE hypermutator group, which is a very small group, very few patients that have a mutation in a proofreading enzyme. And when this proofreading enzyme can't correct spelling errors in the DNA, patients accumulate many mutations in the tumor, which provides ample opportunities to treat. Very rare, but is important to identify. The next in the bottom corner is a molecular group characterized by deficiency in mismatch repair proteins. That means you have lost the ability to repair DNA damage and base substitutions, a very unique molecular characteristics that we treat differently. Then there is a group which has a signature gene abnormality, which is a p53 mutation. It's characterized by more copy number gains and losses, genomic instability, we call that, which we can exploit therapeutically. And then there's a group which we just call is different from the other 3. There's really no significant molecular pathology. And we'll review these now. This is a pie chart that shows a little bit the frequency of these molecular subtypes. So the orange is the POLE hypermutator, which is only about 3 to 4% of all endometrial cancers. Then there's about a quarter of patients which have microsatellite instability, and we'll get to that, what that means. Then there is the dark blue is copy number high. These are patients that have what we call this p53 mutation. They are characterized by frequent breaks, gains, losses, rearrangements, amplifications, deletions. So a different kind of DNA damage that we can exploit therapeutically. And then there's this light blue group, which is, again, the group that has none of the other features, which we call copy number low, because it's very genomically stable and doesn't have microsatellite instability, a POLE mutation, or a p53 mutation, but it has very distinct other features that we'll get to analyze. Now let's jump into the first group. As you can see in the top corner, or in the next slide, this is the microsatellite unstable group. And this is a unique feature among these 25% of patients with uterine cancer that have a non-functioning DNA mismatch repair. And these are 4 enzymes: MLH1, MSH2, MSH6, and PMS2. These 4 enzymes can be either mutated or epigenetically silenced. That means they're switched off, and therefore cannot perform their important duty by repairing erroneously introduced damages or spelling errors in the DNA double strand. When this happens, these tumors develop odd-looking mutations that make a tumor look very foreign and therefore very enticing to the immune system. They can, however, only survive when they're looking so different to normal tissue if they inactivate the immune system. T cells are incredibly efficient in fighting off cancer cells that they recognize and that look foreign. However, if cells look foreign and they are inactivating the T cells, they cannot eliminate these cells. And the inactivation is happening through these so-called checkpoints, such as PD-1, PD-L1, or CTLA-4. There's a long list of immune checkpoints. And what happens is when these checkpoints like PD-1, PD-L1 between tumor cell and T cell engage, the T cell gets silenced and inactivated. With monoclonal antibodies, as you're well aware of, we can now inhibit PD-L1, PD-1 expression, CTLA-4 expression, and therefore re-expose the tumor again to T cells and let the T cells do what they're supposed to do in the first place, get rid of cancer cells. And this led, of course, to the Nobel Prize of two of these individuals, James Ellison and Tasuku Honjo for CTLA-4. James Ellison and the PD-1 inhibition of Honjo. And this has changed the way we treat cancers in general. This has changed how we treat endometrial cancer. And I want to jump right into it. Again, this is a subset of patients that are microsatellite unstable, or we also call it deficient in mismatch repair. And this summarizes the data that have led to the approval of some of these. Keynote 158, Garnet, Phaedra, and a study with avelumab. And you can see this is single agent activity in recurrent patients with metastatic disease. Immune therapy has an outstanding response rate between 50 and 60%. This is achieved with very little toxicity. This is a true breakthrough for this subset of patients. This is just a review of the toxicity. This is relatively well tolerated, low-grade toxicities, as depicted in the bar graph, and the waterfall plot shows you the durable and the significant reduction in size of measurable lesions in just one of these studies, the Keynote 158. Now, this has been moved from recurrent metastatic disease to earlier disease stages, and this is very recent data from the RUBY study, which has incorporated an immune checkpoint inhibitor into the treatment after initial diagnosis of advanced metastatic disease or recurrent endometrial cancer. So that's either initial stage 3 or stage 4 disease or recurrent endometrial cancer. So locally advanced initial or recurrent disease that is usually treated with chemotherapy. And these patients received an immune checkpoint inhibitor, this one called dostarlimab. And this is a large randomized study, was conducted internationally. And as many of you are aware, the data are highly exciting in that on the left side, you can see progression-free survival in the subgroup of patients that are mismatch repair deficient or microsatellite high, with a significant improvement in progression-free survival. And the hazard ratio here is depicted as 0.28. That means there is a 72% risk reduction of suffering a recurrence, which is incredible. Looking at the curves at 2 years without an immune checkpoint inhibitor, only 15% of patients would be without progression. With it, the curve jumps up to 61% that are without progression. If we look at the other subset that is microsatellite stable or does not have a deficiency in the mismatch repair proteins, you can see there is less of a benefit and it's somewhat smaller, although we could argue it still is some benefit with a hazard ratio of 0.76. That means a 24% risk reduction of an immune checkpoint inhibitor in a subset that benefits less than the microsatellite unstable group. If we look at this regarding overall survival, which is a very solid registration endpoint and is most important for patients, you can see a significant improvement in survival at 24 months. So a clear breakthrough for patients with microsatellite unstable endometrial cancer, either at initial diagnosis when early or at recurrence. There's a parallel study called the GY018 study from the US corporate group, which looked at a different immune checkpoint inhibitor, this case pembrolizumab, not dostarlimab, a very similar design. Patients also with locally advanced initial diagnosis of endometrial cancer or recurrent disease that was measurable received frontline chemotherapy versus chemotherapy with carboplatin paclitaxel and the immune checkpoint inhibitor followed by maintenance. This is up to a year's treatment. Large comparative study. And you look at the data, very similar to the slide that I previously showed you, a tremendous improvement in outcomes in patients that are deficient in mismatch repair, where basically activating T cells, re-exposing, and removing the disguise of these cancers and exposing them to T cells again shows a tremendous benefit. And of note, also in the microsatellite proficient group, there was a benefit, albeit less. The FDA has approved an immune checkpoint inhibitor in both mismatch repair deficient and mismatch repair proficient patients, so in both of these groups. However, the benefit was greater in that group where we predicted it to be effective in the mismatch repair deficient group. Now, how does the situation look for the other molecular groups, those that are not microsatellite high? These are the copy number low or copy number high, those that have no other molecular alteration, or those that have the p53 signature. And single agent immune checkpoint inhibitor therapy, as shown here in representative studies, is much less effective, with only about 1 out of 10 patients benefiting. Meaning, apologize, the dogs are barking in the background. I have to scold them. One moment, please. Oh. I apologize for the delay. So the immune therapy for patients that are microsatellite stable is less effective, as shown on these studies. However, when combined with what we call a multikinase inhibitor that inhibits receptor tyrosine kinases of multiple cells, including those relevant in the tumor microenvironment, and when we combine it with a drug that inhibits kinases such as fibroblast growth factor, platelet-derived growth factor, or vascular endothelial growth factor, and this is a drug called lenvatinib, with an immune checkpoint inhibitor, we can suddenly see that the responses are actually seen in about 40% of patients, meaning 4 out of 10 patients benefit. So giving the multikinase inhibitor basically changes an immunologically cold tumor into an immunologically hot tumor and enhances the activity. This is data that was used, or that was a study done in recurrent endometrial cancer. This approach has also moved into the treatment of earlier stages. And again, this is the waterfall plot showing how many patients benefited from this combined treatment. And the drop in the bar just resembles the percent decrease in size of measurable lesions. And nearly all patients had benefit of this combination. However, one of the problems is when they combine it with this multikinase inhibitor, it's evident that the treatment is less well tolerated. Most of these toxicities do not stem from the immune checkpoint inhibitor, but they stem from the multikinase inhibitor, which does cause high blood pressure, diarrhea, and fatigue in many patients. And this led to the fact that even in the comparative phase 3 study, when comparing it to standard of care, where it was superior to standard of care chemotherapy in the mismatch repair proficient group, as you can see here, and here for overall survival. Despite that, it was associated with more toxicity, which led to dose reductions in about 66% of the patients, dose delays in 70% of the patients, and actually 30% of the patients had to discontinue. I think the key message here is that the initial dose that was given, 20 milligrams per day, is not a tolerable dose, and many of you in the audience may have made the same experience, that dose reductions are necessary and make the drug better tolerated. And it's important to understand that this is not necessarily sacrificing the efficacy, because these improvements compared to standard of care chemotherapy were achieved despite having patients requiring a dose reduction. As in the study, 66% had to dose reduced down to either 14 or 10 or even 8 milligram on a daily dose, and nevertheless, it was still superior. So a major improvement for those that are not microsatellite unstable when combining in a checkpoint inhibitor with a multikinase inhibitor. Now let's look at a larger group, which is the group which does not have any significant molecular alterations, or the copy number low, the light blue group. And one of the predominant findings in this group is that it's dominated by estrogen receptor signaling. And just a brief recap, again, one of the key drivers, growth of endometrial cells, but also endometrial cancer cells, is estrogen, which docks on to a receptor, and this then internalizes into the nucleus and turns on transcriptions that regulate cell growth, proliferation. This is a pathway that we can alter significantly, and the most commonly way we do this is by giving a drug as an aromatase inhibitor, which stops the conversion of androgens into estrogen, and by blocking this, we are withdrawing the ligand from the receptor and silencing the signaling pathway. This is a very effective regimen and is the most commonly used anti-hormonal therapy in endometrial cancer. Again, all of this was developed in breast cancer and is trickling down or trickling over to uterine cancer, which is equally hormone receptor driven. A second major breakthrough, particularly in breast cancer, was the addition of so-called CDK4/6 inhibitors to anti-hormonal therapy. And the reason is, when, as depicted in the cartoon, cells or cancer cells divide, they undergo what we call a cell cycle. So there is a phase of DNA synthesis, the S phase, a brief gap, and then cell division, mitosis, followed by, again, a gap. This cell cycle clock is regulated by so-called CDKs, or cyclin-dependent kinases, and there are a number of them, and a critical one is CDK4/6. Inhibiting CDK4/6 can arrest the cell cycle by phosphorylating RB, which is basically the activator, and by phosphorylating it dissociates, and the cell cycle and cell is arrested. So the combination of arresting the cell cycle and inhibiting hormonal signaling synergizes and potentiates the anti-hormonal therapy, and this has now become the mainstream treatment in breast cancer. Well, how did the data look for endometrial cancer? Not as extensive, and we're far behind what the breast cancer field now knows in studying a combination, and this is an example of an aromatase inhibitor letrozole with the CDK4/6 inhibitor palbociclib. This was in a European study by a colleague of mine, Mansour Mirza, which was randomized to letrozole alone versus letrozole with palbociclib, and not surprising, it led to an improvement in progression-free survival with an improvement in secondary endpoints such as disease control rate. This is very consistent with the breast cancer data. This, unfortunately, was not a registration study, and we do not have a registration type study that would get this combination to an FDA approval. So many investigators conduct so-called phase 2 studies to at least get it enlisted into the NCCN clinical trial guidelines. And I want to show you another study that was the combination of a different CDK4/6 inhibitor, abemaciclib plus letrozole, which also showed promising activity, particularly disease stabilization, as you can see on the spider plot, with very little toxicity. This data caught the attention, although not a registration study, to be included in the national guidelines, the NCCN listings, and since that time, thankfully, this combination is more likely to be covered by your insurance as a potentiation of anti-hormonal therapy in hormone receptor positive endometrial cancer. Now let's move on an exciting new pathway that's being explored, and this is a cartoon showing a protein we haven't talked about yet, which is called exportin. Exportin is a protein that shuttles proteins that are important from the inside of the cell to the cell surrounding. And particularly important is the mechanism when it affects so-called tumor suppressors. Those are proteins that control tumor growth, that suppress the development of cancers. And you can imagine when you get rid of these through an overly functioning protein that exports these, that would be detrimental. And therefore, the development of a drug called selinexor, which inhibits this exporting protein and thereby increasing the levels of tumor suppressors such as p53, can then lead to a protective anti-tumor effect. And it's not surprising that when you give this drug called selinexor, an exportin inhibitor, in patients with recurrent endometrial cancer, that you can see in this randomized control study, which compared the addition of this exportin inhibitor as a maintenance therapy after a platinum taxane containing regimen in recurrent endometrial cancer to placebo. You saw a significant improvement in progression-free survival, however, only in the p53 wild type group. p53 wild type means those that had normal p53. In those that had a p53 mutation, the drug was not that beneficial, and the assumption is that this is a pathway that's more relevant if you have a functioning tumor suppressor, p53, and it gets exported outside of the cell. That makes a detrimental impact on cells. If they're p53 mutated, the pathway is already disrupted, and that interference with the exporting process is less detrimental. So this is an exciting strategy that is now being studied in a prospective clinical trial to see that we can improve progression-free survival after standard of care. This is an ongoing study and has a fast-track designation, and hopefully will confirm the initial findings from the subset analysis of the first study. Now let's keep exploring treatment options for this so-called molecular group without significant molecular pathology or findings, which is actually rich on many druggable pathways. We talked about the hormone receptor signaling pathway and about aromatase inhibitors that were combined with CDK4/6 inhibitors. We've seen some improvement on inhibiting the estrogen receptor progression, particularly by developing what we call so-called selective estrogen receptor degraders. So they are not stopping the production of estrogen, they're actually destroying the estrogen receptor. And this is a key difference, because imagine when a cancer cell becomes resistant to an aromatase inhibitor, for example, by an activating mutation in the estrogen receptor. That is very commonly seen in breast cancer patients that have been on an aromatase inhibitor, which then leads to the fact that that estrogen receptor is stuck in the consistently on position. The only way you can turn it off is not by withdrawing hormones anymore with an aromatase inhibitor. The only way you can stop estrogen receptor signaling is by destroying that mutated, consistently on estrogen receptor. And these selective estrogen receptor degraders do that. Fulvestrant is one of them, which has been around for a while. Unfortunately, it's an injection into the left and right buttock every 4 weeks. And there's new developments now with an oral selective estrogen receptor degrader, one called elacestrant. This is approved in breast cancer for patients with breast cancer that carry a estrogen receptor mutation conferring resistance to an aromatase inhibitor. We have so far not studied this in endometrial cancer, but there are trials up and coming in a very, very important pathway. One that would allow you to substitute the fulvestrant, which has the disadvantage of it requiring intramuscular injections, but also potentially being more potent, as shown in the breast cancer field. And again, there are additional targets, particularly in this molecular subgroup, due to the frequency of alterations in genes such as PI3 kinase and AKT. Now, these are proteins that are downstream of the receptors on the surface. meaning they're part of the signal transduction cascade that communicates information from the surface of the cell to the nucleus. And these are well-studied pathways. PI3 kinase activates AKT, which itself then activates TORC1. And therefore, this pathway, be it activated through estrogen receptor signaling or other receptor tyrosine kinases, can be blocked with PI3 kinase inhibitors or AKT inhibitors. And again, this is data from the breast cancer field. You can see a PI3 kinase inhibitor, alpelisib, when given to patients that have a PI3 kinase mutation, improves outcome when given in combination with the estrogen receptor degrader, fulvestrant in this case. But also a novel AKT inhibitor in a so-called basket study. That means many different histological subtypes. You can see mostly breast, but many of these endometrial cancers shows very promising activity. So this is, again, these are two agents that are in development, particularly in breast cancer, but again, trickling down into the field of endometrial cancer. These are fraught with novel potential side effects. One of them is hyperglycemia, as when we inhibit PI3 kinase and AKT signaling, we also render cells more resistant to uptake of glucose, and therefore leading to elevated glucose levels in the serum. However, very promising activity in my opinion. So let's move on to a smaller group, the copy number higher or P53 mutated group. And one of the unique features of this group is that it often harbors an alteration in a gene called HER2. Again, a gene that those familiar with the breast cancer field are very familiar with. In a normal cell, we have about 10,000 receptors of this HER2 protein expressed on the surface. However, if there is a molecular alteration that we call HER2 gene amplification, or increased copy number of the encoding gene, so not two copies, one from your mother and your father, but you have amplification of a normal gene up to 8, 9, 10, 12 copies. These cells express abundance of this receptor, up to 2 million receptors. And this crowded receptor then activates neighboring receptors, and that leads to an unopposed stimulation of growth. Trastuzumab, one of the first targeted HER2 inhibitors, interferes with this receptor dimerization or activation and leads to improved outcome in breast cancer as the main treatment, but also in endometrial cancer. And we're grateful that this study was conducted by a colleague of mine at Yale with great persistence, adding trastuzumab to standard of care carboplatin Taxol in recurrent endometrial cancer, which led to significant improvement and now NCCN listing as a possible treatment in patients with endometrial cancer that have HER2 new gene amplification. Let's move on to a different pathway, DNA repair. And many of you are aware that we have a number of PARP inhibitors approved for the treatment of ovarian cancer. And the main question was inhibiting with DNA repair, particularly single-strand break repair, lead to efficacy in endometrial cancer. And again, as a background, when we inhibit single-stranded DNA repair, it only becomes lethal for a cancer cell that has no backup DNA repair mechanism, and that is double-stranded DNA repair. So only when you have a BRCA mutation or deficient double-strand break repair, single-strand break repair is effective with a PARP inhibitor, and that's why the PARP inhibitors work particularly well in BRCA mutation carriers or those that are BRCA-like in ovarian cancer. Well, in endometrial cancer, we don't have this framework, and so this study is very interesting that looked at actually combination of a PARP inhibitor in endometrial cancer, and this is recurrent endometrial cancer or high-risk early-stage endometrial cancer, when combined with an immune checkpoint inhibitor. In this case, it was durvalumab. So it was the PARP inhibitor olaparib with durvalumab versus durvalumab alone. And it's interesting that in this group that was mismatch repair deficient, whereas you can see the immune therapy made the biggest impact, The PARP inhibitor didn't add much. However, when we look at a different subset of patients, these are the mismatch repair proficient endometrial cancer patients where immune therapy didn't add that much, but this is where the PARP inhibitor may add additional benefit, as you can see at the 12-month time point and the 18-month time point, that the progression-free survival actually improved from 44% to 59%. So I think stay tuned. Will there be a role for a PARP inhibitor? Possibly yes, but particularly in a molecular subtype that we would call mismatch repair proficient. Now, in addition to these targeted inhibitors of these diverse signaling pathways that I've shared with you, there is a whole new revolution going on in the treatment of endometrial cancer, and that can be summarized as the development of novel antibody-drug conjugates. And the principle of antibody-drug conjugates is that we try to identify a surface protein that is only found on cancer cells and is not expressed on normal cells. And this is just a cartoon showing you some of these cancer-specific surface proteins, where on the right side you see monoclonal antibodies attaching to them and binding to these surface proteins. Well, if we attach chemotherapy to those monoclonal antibodies, as shown in the cartoon here, with a relative size ratio, we develop basically a targeted vehicle that to deliver chemotherapy selectively to cancer cells. And if the protein is not expressed on normal cells, it will not cause the same toxicity. So that's the excitement about antibody-drug conjugates, that we have a drug available that's more targeted, but also spares healthy cells and lowers the toxicity, increasing what we call the therapeutic window for the use of a drug. And this is another cartoon showing you the size relationship of the monoclonal antibody and the attached chemotherapy. Now, there are a number of ADCs in the meantime approved. The top line here you see are those approved in blood cancers, and the bottom ones are the drugs that are approved in solid tumors. And the first two, trastuzumab emtansine and trastuzumab deruxtecan, are approved in breast cancer. And two of these, as you can see, tisotumab vedotin on the far right, is approved for cervical cancer, and the mirvetuximab soravtansine is the first ADC targeting the folate receptor that was recently approved for ovarian cancer. And I want to briefly guide you through potential targets that are currently being pursued in clinical trials for endometrial cancer. These are proteins that may be familiar to you, such as HER2, folate receptor, tissue factor, TROP2, B7H4, Claudin-6, B7H3, and AXL. These are all expressed to varying degrees on tumor cells and are not or lower expressed on normal cells, and therefore ideal targets for development of ADCs. Now, it's become so crowded. You can see this is a long list of ADCs that are currently in clinical trials, with the many targets and the different companies that are developing them. And I want to focus in on three, just due to the limitation of my presentation here and the time constraints: TROP2, HER2, and folate receptor alpha, which are the furthest along, I think. And these are now shown in red. For HER2, we have two HER2 targeting ADCs. One is trastuzumab deruxtecan, and a newer one from BioNTech called BNT323. Folate receptor targeting ADCs, we have mirvetuximab soravtansine, and then we have a drug called Rina-S, which targets the folate receptor with a different payload, or the Immunogen 151, a second-generation drug from Immunogen with a more potent payload. Then we have actually three drugs in development in endometrial cancer that are targeting TROP2. So let me briefly review a very promising drug called trastuzumab deruxtecan. This was a study conducted across many tumor types, including endometrial cancer patients. These were 40 endometrial cancer patients with extensive prior treatment. And what's very, very impressive is that in tumors that express HER2 on the surface with varying degrees of expression from 1+ intensity, mild, to moderate, to high, 3+ intensity, the responses range between 25% and 84% with this HER2 targeting ADC. This has led to the approval of this HER2 targeting ADC in GYN malignancies such as cervical cancer, endometrial cancer, and ovarian cancer due to its outstanding activity. This is contingent on further confirmatory studies, but it is proof of principle that targeting a receptor can lead to greater efficacy and less toxicity. There's another HER2 targeting ADC in development from BioNTech, 323, with a different payload targeting HER2. Very promising activity. And this is all data that was recently shared at the European Society of Medical Oncology meeting a few months ago with very durable responses. So more clinical trials coming with this agent. This has also led to what we call a fast track designation of this BNT323 as a HER2 targeting ADC with a different payload than TDXD. This opens up a Pandora's box, and this is pertaining to who should get this HER2 targeting ADC. And if you recall, there were different responses based on the fact that patients had 1+, 2+, or 3+ expression. Accurately measuring HER2 expression therefore becomes more and more important now with this drug available. And one of the problems that the breast cancer field has known for many years is that it's not always consistent getting the same test results, particularly when you compare local tests with central testing. And this graph shows you that test results can vary, that 3+ intensity can drop down to 2+ intensity, or even some 1+ intensities can actually be scored as a 3+ intensity when performed at a central lab. The other is sometimes testing different tissue specimens, like the original hysterectomy specimen from the surgery, or doing a new biopsy on a recurrence can affect test results. So we don't really understand all this detail. And for you as patients and patients advocates, it's important to understand that when having access to such an important new targeted agents, it may be worthwhile retesting tissue or questioning a testing result and resubmitting it to a central reference lab just to be sure that you really have low HER2 expression and you're not a 3+ or a 2+ where you would have 50 or maybe even higher response rate. Because this is really not rock solid when applying immunohistochemistry to protein surface markers. Another example is TROP2. TROP2, there are 3 drugs in development in endometrial cancer, and you can see on the top, this is a normal cell. On the surface and the bottom, you can see these tumor infiltrations into the depth of the tissue, showing high TROP2 expression. Saxetumab govitecan, again a drug, has been initially studied in triple-negative breast cancer, showed very promising activity and is moving forward in endometrial cancer. There's another, saxetumab tiromotecan, which has a different payload, not SN38 as the previous drug. This is a topoisomerase inhibitor. This is actually moving forward into a large randomized study where patients with not more than 3 prior lines of therapy with recurrent endometrial cancer will be randomized to standard of care, here doxorubicin or paclitaxel, to the new TROP2 targeting ADC, a very exciting study. In a phase 3 study, a necessary step before obtaining FDA approval. Another novel agent targeting the folate receptor, and again, there is none that is approved for endometrial cancer, as the folate receptor targeting ADC mirvetuximab is only approved for ovarian cancer. But this is a drug that's been extensively studied in endometrial cancer that shows folate receptor expression with a topoisomerase inhibitor, and you can see there is an overall response rate of 50% in patients with ovarian and endometrial cancer, and this has also received fast track designation as moving forward in endometrial cancer. So the take-home message regarding these ADCs are summarized here around the 3 proteins, HER2, TROP2, and folate receptor alpha, with promising ADCs in development. The big question is, how do these relate to the molecular subtypes that we have? And we haven't really understood other than HER2 being more enriched in the p53 mutated subtype, where the other groups are enriched for, and this is ongoing research. I wanted to conclude a little bit with something that we're doing ourselves at UCLA, and that we've identified a very unique protein that is called Claudin-6, beyond the three that I've reviewed. This is moving into phase 2 clinical trials in ovarian cancer, and we have a phase 1 study open for patients with recurrent endometrial cancer. Claudin-6 is a tight junction protein, and I'll briefly review that. It has advantages over other targets that I briefly discussed, such as TROP2 or folate receptor, as these 4 graphs show the expression in normal tissue. And you can see Claudin-6 in all of these normal tissues, from left to right, 60 normal tissues, is much lower expressed than compared to TROP2, which in some normal tissues, as the circle indicates, lung tissue, can be very highly expressed. So in our experience, this is an even cleaner target for an ADC, as it's expressed in cancers, but absolutely missing in normal tissue, much lower levels than other targets that we've been pursuing so far. So we're very excited to move this forward with a new antibody-drug conjugate with the so-called MMAE payload, and this went through what we call a standard phase 1 study, as shown here, and has shown very promising activity, particularly in endometrial cancer and ovarian cancer patients. So let me conclude with our new molecular understanding, particularly of a group that's microsatellite instable, of a group that is described as having no major significant molecular alteration, but has abundance of signaling pathways that can be targeted, such as exportin, the hormone receptor signaling pathway, the PI3 kinase and AKT signaling pathway, and multiple hormonal agents, such as aromatase inhibitors or new selective estrogen receptor degraders. And then lastly, we have a group that we call the p53 mutated copy number high, which has druggable targets like HER2. It also has potential for PARP inhibitors to be added to chemotherapy. And last but not least, a very exciting field evolving that is utilizing drugs, ADCs that target surface proteins, particularly HER2, TROP2, folate receptor, and Claudin-6, which I think will provide ample new opportunities for treatments for patients, initially with recurrent disease and then moving up to early disease stages. And that concludes my talk, and I hope I was able to share a little bit of the excitement in this field, and I'll open it up to questions.
Thank you so much, Dr. Konecny. That was really interesting and informative. So we'll start the Q&A. That we had a lot of pre-submitted questions, and you can still submit questions in the Q&A section at the bottom of your screen. And so we'll pick and choose a few from the pre-submitted and the live for whatever we have time for. So Dr. Konecny, I'll start with this one. Which is more important in treatment decisions, the type of uterine cancer or the biomarkers?
I think they're connected. So we use the biomarkers to really identify the molecular subtype, but ultimately it's the biomarker that counts. So, you know, those 4 molecular subtypes are an evolving classification, but they were developed because they have a differential expression of various biomarkers or alterations, be it mutations or copy numbers. So the biomarker is what I'm looking for when I develop a drug, because I want to inhibit that, either the biomarker on a surface protein or a mutation that activates aberrant signaling. But it does, the molecular classification is just a different way of looking at it. Not anymore looking at, oh, it's endometrial cancer coming from the uterus. No, it's actually many different diseases that are summated into just one type of a disease.
That makes a lot of sense. And with all these new treatments, have recurrence rate expectations changed?
Well, as with all new drugs, they are initially first assessed in patients with recurrent disease, and that's where we see successes such as increased response rates, improved progression-free survival, and overall survival. However, that has not yet carried over to the initial slide that I showed you that an increasing incidence and mortality actually of endometrial cancer. And we hope to see with these tailored treatments that over the years that we will see a decline in the rate of endometrial cancer and an increase in cure and a drop in mortality.
Thank you. Somebody's asking if PET scans are still a good tool for surveillance of uterine cancer, or are there other blood tests like ctDNA that might be better?
Well, great question. PET-CTs are still the Cadillac and the gold standard, I think, for imaging, because they give you, in addition to the X-ray findings, information on metabolic activity of something you see on a scan, lets you differentiate between scar and actively growing tumor. But there are very many new novel blood markers that we can use to follow for assessing treatment response, or actually use for early detection or monitoring of someone's in remission. These are basically summarized as cell-free DNA. There are tests where we can monitor DNA that is shed by tumors into the circulation, and they are in development now. I wouldn't say they're validated yet, but there are some very interesting new developments, and we've been using them in patients either as monitoring remissions or assessing treatment response.
Thank you. Somebody asks if there's work being done building the sequencing standards of care for second, third, and fourth line treatments for each of these 4 molecular types.
Sorry, you said sequencing of treatments, right?
Sequencing, they said sequencing / standards of care for second, third, and fourth line treatments for each of the 4 molecular types.
Yeah, sort of, if I understand the question right, are there any pathways that could be developed where we could standardize, what's the first treatment, potentially the second and the third,
Right.
And ranking them by their efficacy for each of these subtypes? I think that's needs to still be done once we have a better understanding of each of these components. In the end, as we have standard pathways for endometrial cancer in general, mostly based on stage now, I think molecular subtyping will factor in and will allow us to stratify these treatments. We don't have these uniform pathways now. It really comes down to developing and picking these treatments with your physician and your decisions also, weighing toxicities versus the potential gain, lining different options up. But often, sometimes it's just availability which allows you to choose one. Is the drug covered? Do you get access to, a drug that's not yet FDA approved, but maybe NCCN listed? Is there a trial open close to you? So those are the factors that really have a greater impact on these pathways, I think.
Sure. I think I'm going to now pass the rest of the Q&A over to Corby.
Okay. I'm just trying to see which ones we have here. Someone would like to understand the use of Herceptin for HER2-positive uterine cancer and how long to stay on it versus being treated with Enhertu.
So these are two great questions. These are very different settings. The use of trastuzumab has been studied in endometrial cancer by adding it to standard of care carboplatin, paclitaxel, and giving it in patients in that setting for stage 3 or 4 initial diagnosis, advanced disease, for 1 year. In breast cancer, we also give it for 1 year and not longer. That is basically an adjuvant treatment. And for that to work, you need to have what we call gene amplification. So you need to have multiple copies and this excessive expression of the HER2, not 20,000, but 2 million receptors per cell. With Enhertu, it's different. Enhertu, you do not need to have constituent activation of these HER2 receptors. You're just using HER2 as a marker that identifies a cancer cell and separates it from a normal cell. So we don't need to have the receptor activated. That's why the drug works even if you have low expression, like 20,000 receptors, or above 50,000, 200,000. That's the 1+, 2+ lower intensity, where we still see meaningful responses. We don't have an activated HER2 receptor. It's simply a marker that identifies the cancer cell and differentiates it to a normal cell. And therefore, Enhertu works in far greater number of patients. Because if you look at the data, how many patients in endometrial cancer have HER2 amplification? Probably only about 5–6%, more in the serous subtype. But how many patients have HER2 expression? Probably on half of the patients. So different biology of the receptor for either a monoclonal antibody that by itself inhibits receptor activation versus protein-directed ADC.
Thank you. Let's see. Is T53 subclonal considered mutated and outside of the NSMP category?
So I think the question is a p53 mutation subclonal. That's an interesting question. That means when you send out for sequencing, it is only found in a small proportion of cells. Would that be called p53 mutated? I would say that's a tough. That's where I would reach out to the lab. Officially, it's not consistent with having a p53 mutation that you find in nearly all, like high allele frequency in all malignant cells. If it's subclonal, it may only be detected in lower allele frequency, meaning in a subset of cells. But those are cases where I, as a physician, follow up and actually talk with the molecular pathologist and say, how frequent did you find that? How would you interpret this result? It's a distinct definition of having a p53 mutation only in a few cells and may not lead to the same activity of your targeted approach.
Are there any hopeful treatments for carcinosarcoma, p53 aberrant?
Yeah, so also a great question. The carcinosarcoma would be generally summarized into the p53 mutated, copy number high. It's generally not microsatellite instable. It's generally not hormone receptor positive or wouldn't belong to the group which we called no significant molecular pathology. It is, although called sarcoma, carcinosarcoma, still considered an epithelial malignancy, which has sarcomatous differentiation. But it would be, for example, important to look for HER2, as it's commonly altered in that disease. It would be treated like a microsatellite stable when considering immune therapy, such as an immune checkpoint inhibitor with a multikinase inhibitor, lenvatinib. So I think you can account for the molecular specifics of this tumor when looking at individual biomarkers.
Okay. I think we're at the time. Right. That's all I have. Because
yeah, I think so, probably. Yeah.
Because they're all deep questions, Dr. K. So, thank you. Is this my part or your part?
Yours.
Thank you so much, Dr. Konecny, for your thoughtful and thorough answers to these questions. We'll have a recording of this program available at our website in 1 to 2 weeks. Please also check SHARE's website for upcoming and educational programs, podcast episodes, and support groups. And don't forget to follow us on social media.
And please take a moment to complete the survey at the end of the webinar. The survey will pop up in the browser when the webinar ends. And the link will also be in the follow-up email. And all surveys are anonymous. And I wanted to add my thanks, Dr. Konecny, to Corby's really fantastic presentation. And we're so delighted that you could join us. And this concludes the webinar. So thank you again, everybody, for joining us.
Thank you.
And have a great rest of the day or evening, depending
Thanks
where
very
you
much.
are.
Have a great evening. Thank you.
You too.